Hi, I'm Sarah Green and I'm the Executive Officer of the Health Services Research Association. We run these webinars, try and run them monthly, both to disseminate members' research and to promote the best health services research in Australia and New Zealand. Other activities of the association are our biennial conference on health services and policy research, and our next conference is being held in Auckland at the end of this year, the 4th to the 6th of December, on equity, and we'll be calling for abstracts for that conference, I think opening in April, so good opportunity to get your research ready in order to submit an abstract. Our webinars are 3, but we just encourage anyone online today to please go and have a look at our website. I'll send out the link with the follow-up email after this event, and have a look at our other services and benefits and think about joining us. A couple of housekeeping issues for this morning. As I said earlier, you should be able to see the slides and the talking heads at the side of the screen, but we can't see or hear you. But you can make comments using the chat button at the bottom of your screen. If you move your mouse around, you'll see the little icons at the bottom of your screen. And questions for Liz can be typed in the Q&A box at the bottom of the screen. And Catherine, who's going to chair this morning's session, will keep an eye on those questions and either raise them as Liz's talk progresses, or we'll ask them at the end of the session. So just keep typing your questions in as they come to you. We are recording the webinar this morning, and it'll be on the HSR website in hopefully sometime tomorrow, and I'll send out a link to anyone who's registered. And that's all I had to say. Catherine, who is a member of the Health Services Research Association Executive Committee, is going to chair this morning's session, introduce Liz, and handle the Q&A for us. So I'll hand over to Catherine.
All right, thank you very much, Sarah. I'm really delighted to be chairing this session this morning with Dr. Elizabeth Lynch. Liz is a stroke physiotherapist based at the University of Adelaide, and she's also the joint recipient of the HSRAANZ Research Impact Award for 2018, which is recognising her work in the field of managing rehabilitation needs of people after stroke. As an occupational therapist myself, I was really pleased to see work by allied health professionals being nominated for this award. I see a huge amount of work that's done by allied health professionals, which falls very much into the sphere of health services research. But it's not always identified as such. So, in my interactions with allied health researchers, I often find people associate their work with their discipline or the condition that their research is concerned with, rather than necessarily viewing their work through the lens of the benefits that it might bring to the health system. So particularly welcome to all those allied health professionals in the audience, and I hope that this might inspire you to think of your research perhaps as health services research, as well as the other ways that you might view it. Allied health are often working at the points of transition between parts of the healthcare system, whether that's in discharge planning from acute hospitals, preparing people for life in the community after rehabilitation, or also managing chronic illnesses in the community to prevent hospital admissions and emergency presentations in the first place. And ensuring that these transitions work efficiently and effectively is a vitally important part of a healthy health system, and therefore it really is core business of health service researchers. So the work that you'll hear about today looks at the issue of transition from acute to rehabilitation care for patients after stroke. So thanks once again for joining us, and I'm very pleased to pass the microphone over to Dr. Elizabeth Lynch. Thank you, Liz.
Thank you very much for having me on. So I'm pleased to be able to present this work. So it's been a work that started in 2012 and is still ongoing now. So this was the basis of my PhD, looking at assessing and managing the rehab needs of people with stroke. So I've acknowledged my supervisors here on the opening slide. So what are we talking about is stroke rehab in Australia, what was happening before I started my project, then what we did to try and improve the way that stroke rehabilitation needs were being assessed and managed, and then how effective those two interventions were. And then that was the end of my PhD, and we've been doing ongoing work since then, looking at trying to get some impact from our work, but through dissemination and liaising with the Stroke Foundation, and lessons I've learned along the way that have helped with this project getting into kind of the guidelines and into practice. So stroke affects 1 in 5 Australians. Our recent, we always used to say it was 1 in 6, but the paper just out in the end of last year is saying that 1 in 5 Australians will have a stroke at some point in their life. So it is very, very common. It's the leading cause of disability in adults in Australia and one of the leading causes of death. So it's a really significant problem. Significant amount of our health resources are being used up to care for people with stroke. And nearly 2/3 of people who are living with stroke in the community need help for daily activities. So this is when rehab is really important, because rehabilitation can help people regain function and reduce their disability. And so it's probably just worth pointing out, so that after a stroke, some people will die, and that's the nature of having a stroke. Some people will fully recover, but the rest of the people will be left with some form of signs of their stroke. And this is when rehabilitation can be really helpful to help them get back their function, or and if they don't get back their function, learn to live with their function that they have remaining. But in order to get into rehab, there's market inequity in access to rehab. So some work coming out of Canada showed they did this blanket assessment of everybody who had a stroke, and using this kind of protocolized assessment, they were able to define that 37% of patients with stroke needed inpatient rehabilitation, but they didn't have the services, so only 28% of people accessed rehab. So they were able to really clearly define that there was a shortfall in the available inpatient rehabilitation services for the Canadian population. Work that was coming out of Australia before I started my PhD was showing that there were significant problems with the way rehabilitation assessments are being conducted. So one study was looked at rehabilitation consultants, so the people that would go into hospitals and make decisions about whether someone would need inpatient rehabilitation or not. And these were all in Victoria. And they spoke to these rehab consultants and asked, how do you determine if someone needs inpatient rehabilitation? And all of them said, I'd look at their prognosis. And then these rehab physicians or consultants, I can't quite remember, were then given identical case studies of patients. So just on paper, this is what this patient looks like, this is their diagnosis, this is what their current function is. And there was a marked disagreement between these rehabilitation specialists about who had a good prognosis or not. And so that was a really neat study looking at, it's really hard to define who should get into rehab or not. Even the experts can't agree, experts working within the One Health system. And these are people that are getting assessed. But we know in Australia that not everyone gets assessed, doesn't have their rehab needs assessed. So in 2013, less than half the people, almost half the people had their rehab needs assessed, which fell well below Canada, which fell well and truly below UK and USA, where most people get some form of rehab assessment. Oops, sorry. Yep, pressing the wrong buttons. How do I get rid of that? So what happens after a stroke? In the ideal, this is what should happen. A person with stroke gets admitted to a hospital. The acute staff will screen that patient, and if they're not fully recovered, refer them for a rehab assessment. Then a rehab specialist can assess them for their rehab needs and then refer them on to a rehab service where that person can access rehab if they actually need it. But we know that doesn't always happen. So best care is that people get admitted to a stroke unit. But in Australia, not everyone gets admitted to a stroke unit. Latest figures are about close to 7 out of 10 will go to a stroke unit. You get much better care in a stroke unit than you do in a general medical ward, and yet not everybody is receiving that care. Depending on the hospital you go to, referral rates can vary markedly. So again, this is out of Victoria. Similar people with similar levels of disability, depending on the hospital, some patients with a similar level of disability, 27% of them would be referred, whereas in a different hospital, 73% of patients that looked similar would be referred to rehab. So there's really cultural practices within hospitals that are very varied. Acute staff tend not to see the rehab needs of people with severe stroke. So these are people who, particularly if their consciousness is affected. And people with mild stroke, there's a lot of work coming through showing that the people with some of these subtle difficulties, so things like high-level cognition, managing your money, being able to read, being able to walk around the shops up and down stairs without holding a banister, these sorts of things often get missed, that don't get picked up in the acute hospital, and these people don't get referred for rehab sometimes. When people are being assessed by rehab specialists, the criteria used by specialists aren't always valid. So things like social history doesn't actually affect whether or not you're going to improve with rehab, but people do consider that when they're deciding whether or not to refer someone to rehab or not. When I started my project, only 45% of people were being assessed by rehab specialists. There's a lot of information that if you have a family advocate, you are much more likely to be assessed, which makes you think, pity the poor people without families who know the health system, particularly, and we see that with people from different cultures who don't know how to advocate for themselves, or people that are just really unfamiliar with hospital systems and don't know that they can actually ask for extra input. An assessor opinion, as I mentioned briefly, will vary between different specialists. And then if a person does have rehab needs, if they're in an acute hospital that has a really good relationship with a rehab hospital, they're much more likely to go to rehab. Rehab centres understandably have their own priorities, so they have staffing that can cater to a particular cohort of patients, and that's as it should be, but the people that fall outside the scope of those rehab centres won't always be able to access suitable rehabilitation. So there was a lot of noise coming out about these inequities in assessments, and so it started off in South Australia, but then was picked up by the Australian Stroke Coalition nationally, working to improve the pathway of having your rehab needs assessed and managed. And so this culminated in the development of the assessment for rehabilitation tool, which was taken on by the Australian Stroke Coalition. And so the premise of this was that every person should receive the right rehabilitation in the right place at the right time. So this was developed in 2011 based on an extensive literature search looking at which patients will respond to rehabilitation, which people will benefit from rehab. Surveyed clinicians, there was an expert working group of researchers, clinicians and consumers who then had input into this tool, which was then pilot tested in 6 states in Australia. It was then just tweaked a little bit after pilot testing, and then it was released in December 2012. So this tool is a little different. It's kind of philosophically different to the way that certainly I was used to assessing people for their rehab needs. So this looks at, would the person benefit from rehab? Is there any evidence that they wouldn't benefit from rehab? Which is a little different to how we tended to assess, which is, does this person meet the criteria of the rehab service? So this is what the tool looks like. It's got 14 different domains, and the idea being that if the person is not back to their pre-stroke level of function in each domain, then rehabilitation would be indicated. If their rehab needs could be managed at home, then rehab would be best suited at home. And we know coming out of some of the systematic reviews looking at home rehab versus centre-based rehab for people who are able to be managed at home. Also looked at participation and environment. So with this, rehabilitation is indicated for every person with stroke unless they've made a full recovery, unless they're dying, if they're so severely affected that they're non-responsive, so they're in a coma. So this is quite different from drowsy. A lot of times people will think drowsy is non-responsive, but no, this is kind of coma level non-responsive. or if they have good cognition, their cognition has not been affected by their stroke and they're refusing therapy. So that's reasonable as well. So what we wanted to do before we started the project was to look at how were patients being assessed for rehab on acute stroke units, knowing that the acute stroke units provide the best level of care. So did some observations at 2 stroke units over 4 weeks and just followed the staff around, took notes and looked through medical records, and then did some inductive content analysis on the information that we collected. So I observed 24 team meetings. So I looked at 5 multidisciplinary case conferences at each stroke unit. Also looked at things like ward rounds, nurse handovers, nurse therapist handovers, and all collected data on 64 patients. So rehab was mentioned for most patients. So for 78% of people, rehab was mentioned at some point within these sorts of team meetings. And when rehab was mentioned, most times it was decided to refer them on to rehab somewhere, either, and that could be at home or in an inpatient rehab facility or in the community. 3 people, it was raised, does this person need rehab? And they weren't for referral, 1 because the patient didn't want it, 1 because the patient was deemed to have made a full recovery, and 1 because it was deemed that residential care was the most appropriate path for this person. And so this was someone who had been living at home independently before their stroke. Rehab wasn't mentioned for 14 patients, and none of these people were referred to rehab. So 7 people went home without any mention of rehab and without any rehab follow-up. 4 people went to residential care without any rehab follow-up. Again, these people were all living at home prior to their stroke, and 2 people were on a palliative care pathway. And it's just worth noting that we saw different kind of management plans with people who didn't speak English. They did eventually get on the appropriate pathway for what they wanted, but it was a much more circuitous route. Staff were making assumptions about what the family would want. In one case, the staff assumed the family wouldn't want the stroke survivor to go to inpatient rehab because he didn't speak the language. They assumed the family would want to look after him at home. And it wasn't until the granddaughter took the day off school so that she could be there on ward round to say, no, we don't want to take him home, it's too heavy, he can't walk yet. And so then that was fine. They could put that plan in place without any issues at all. And on the flip side, there was another family who the staff thought the most appropriate plan for the stroke survivor was to go to residential care, and the family wanted to take him home. And that was quite a tricky pathway for that family, and it ended up having quite a lot of different staff involved until the staff kind of understood the family's perspective that they did want to take the stroke survivor home. So the interpreters weren't being brought in on a routine basis, which perhaps could have made the management of these people a little bit easier. So we know that having rehab discussed means you're more likely to get rehab. What is it about a person that makes rehab get discussed for them? So it was always discussed for people who had obvious signs of stroke and were noted to be improving in their speech or mobility. And if they were alert, being alert was clearly really important. These people were anticipated to go home or to hostel level care. And these people received active input by the therapy staff, by the physios, OTs and speech pathologists. Rehab wasn't discussed for people with very mild stroke-related symptoms or no apparent symptoms who were expected to go home. These people would be discharged from physiotherapy and not always seen by occupational therapy and speech pathology, which makes you think, what about these people with these really high-level cognitive changes? They're not actually being assessed for presence or absence of these. And rehab wouldn't be discussed unless the family kind of got involved for people with the really severe strokes, so with people with reduced alertness, severe hemiplegia and dysphagia. These people would be anticipated to go on a palliative care pathway or to go to residential care. And these people also didn't get active input, so they'd be getting monitored by the speech pathologist and the physiotherapist and without any occupational therapy input. So at one of the sites, knowing that I was only at 2 sites, one of the sites, the physiotherapist would assess their sitting balance, but then just monitor their limbs. At the other site, they wouldn't routinely assess sitting balance either. So we wanted to improve these systems, and so that we were actually making sure that every person had their rehab needs assessed, and if they had rehab needs, were referred to a rehab service. So we had conducted a cluster randomised controlled trial at 10 hospitals in South Australia and New South Wales. 5 hospitals were assigned to receive a multifaceted intervention. So this is quite hands-on. So I went out to each site and talked about the assessment for rehab tool, talked about why it was developed, how it had been used. We staggered recruitment of hospitals, so that hospitals that we started later, I was able to tell them how other sites were using the assessment for rehab tool. Did medical record audit and provided feedback to staff about how rehab assessments were going. Ran a workshop to look at barriers to what would make using this tool hard, and then subsequently developed strategies to overcome those barriers. Each site nominated someone who would kind of champion use of the assessment tool, and then I'd send reminders either in person or phone calls or emails to that site champion. 5 hospitals just received education, so I went out and talked about the assessment for rehab tool and provided copies of the assessment for rehab tool, and again gave them information about how other sites had used the tool. So when we wanted to see were the interventions effective for improving rehabilitation assessment practices, the hypothesis was that the multifaceted intervention would be more useful than simply education. We wanted to know what were the barriers and enablers to improving rehab assessment practices as well. So of the 10 hospitals, 8 of them had acute stroke units. So and 2 of them were regional centres where they had this much more comprehensive model, but it was not like the general acute stroke unit model. So these data are only from the acute stroke units. So we asked them, how were you using the assessment for rehab tool? So 3 sites used all the functional domains. They went through each of those functional domains and was the person back to their pre-stroke level of function or not. 4 sites didn't do that because they didn't feel the need, but they would then document, does this person have rehab needs, yes or no? And if no, what were the reasons? And it was, palliative care, refused, full recovery, or non-responsive. And 1 site chose not to use any aspect of the tool at all. 5 of the sites reported using their method of using the tool with every patient. 2 sites said we try, but we sometimes forget. And 1 site, again, didn't use it at all. And interestingly, 4 sites said that when they're not using the assessment tool, domains such as continence and mood tended not to be documented. But these weren't all sites that chose to use all the functional domains in summary. So people were able to identify that the tool did provide a much more comprehensive assessment, but that didn't drive them to want to use the tool necessarily. And interestingly, 4 sites said, yep, we're happy to change the way we identify rehab needs, but they weren't always happy to refer to rehab if they'd identified rehab needs, which was an unanticipated finding. I'll go into that a little bit further. So we asked people, what do you think about? What are you thinking about when you assess someone for rehabilitation? And it came through very, very clearly that the perceived likelihood of being admitted to the rehab service was a very key driver in assessing. So our rehab assessments are based on what we know the rehab facilities require. Anticipated discharge destination. If you're anticipated to go to a nursing home, rehab wouldn't be considered. If you're anticipated to go home or to hostel, then your chances of rehab were higher. People with very severe strokes tended, in conversation, staff would identify these people as not needing rehab. People were able to identify that if you had a noisy family, if you had someone who was asking for rehab, that would change. That could change whether or not you referred someone or not. People needed to be medically stable in order to be considered for rehab. younger people, particularly if we're talking about some of those really severe strokes, people with a severe stroke who are young were more likely to be considered for rehab by staff. And perceived motivation and participation and how people were progressing in therapy also came through as a key consideration when assessing whether someone had rehab needs. So we use it's one of the ways of analysing data. There's this framework, it's called the Theoretical Domains Framework, and we use that to analyse information about what was it that influenced whether or not you changed your practice. And how people perceived their social role was, their role as a professional was quite instructive. So if they felt that use of the assessment for rehab tool was useful to guide their professional decisions, they would use the tool. And if they thought it was not useful, they wouldn't. So at one site that did use the tool, I think the tool highlights areas that we wouldn't have always discussed previously, cognition and the emotional side of things. So this site was one site that really championed use of the tool, found it really very useful. Whereas another site that chose not to use it, if I thought, or any of the clinicians thought, that use of the tool would have been valuable in terms of lifting our game, excuse me, and benefiting our patients, I've no doubt we would have adopted it. So a number of sites felt like this tool is doing nothing that we're not doing already, so there was no added benefit of using it. The criteria of someone having rehab needs didn't always gel with staff. Sometimes it did, sometimes it didn't. So a site that did use it, everyone is considered for rehab on the ideal basis rather than on the basis of perceived system constraints. Whereas at another site, these staff really didn't agree with the concept that everyone could benefit from rehab. So if you're not dead and you're not in a coma, theoretically you should be for rehab. But people with severe strokes are really not a rehab candidate. So these people didn't agree with the idea that people with severe strokes could benefit from rehab, or didn't. Everybody seemed to think that using these criteria to identify rehabilitation needs would highlight that there's not enough rehab services for people with stroke, and this could either be a good thing or a bad thing. So it was good if the tool is going to show the gap between who can access rehab and who should access rehab, and these people were happy to identify rehab needs. Whereas if people deserve rehab and they're never going to get it, we don't have the services, that creates a problem with families. People were really reluctant to identify rehab needs if it was going to cause conflict. And this came out of the site that chose not to use any aspect of the tool at all, because they were really worried about medico-legal questions. If we were recommending rehab and then that couldn't be provided, that was something that could come back to us. So these people were unwilling to identify rehabilitation needs according to these criteria on the off chance, in case they'd identify rehab needs that couldn't be managed, and then they were worried about being sued by families. The influence of the group was very clear. At each site, the acute stroke unit team had a united front, so that the team, if they liked the tool, I think this is the nature of stroke units. Staff tend to work really cohesively and in an interdisciplinary way. And so if the team liked the tool, there was quite a united front that the tool was useful. Similarly, if the team thought that the tool was not of benefit to them, the team as a whole would reflect the same sort of ideas. And we didn't try and tease that apart, but that was quite clear that there was quite a cohesive understanding within each workplace. And we did note that we didn't involve rehab teams as part of the study, which was an oversight, and hindsight's a wonderful thing. I would have definitely, if I was to do this again, would definitely have much more involvement with rehab teams. But the rehab team was a barrier at almost every single site, probably because we didn't involve them. So at one site that was using the tool with every patient, I'd say the tool is not taken on board by rehab. I think what would help us is if the rehab team were using this or asking for it. So at this site, the team used the assessment tool with every patient, would provide that to the rehab assessors when they came on the unit, who apparently wouldn't pay any attention to their form. At another site that was happy to use the tool, any patient that wasn't at their baseline would be indicated for rehab, but if they might have dementia, so I wouldn't refer them because that would just destroy my relationship with the rehab facility. So maintaining good relationships with the rehab hospital was deemed very important, which is completely understandable. But we hadn't anticipated that staff would be reluctant to refer to rehab teams. And certainly when I presented this at multidisciplinary conferences, some of the rehab medicine attendees have been quite dismayed that acute hospitals would perceive them to be doing services that would punish staff for referring. But I think, it's one of these things where we need to get everybody in the room together so that everyone can represent themselves in a fair and equitable way, which is something that we didn't do with this project, which was a shame. The tool would be used if you could embed it as part of your meeting, whereas other sites chose not to use it because it was like an extra piece of paperwork. We've got our procedures in place. We don't want to double up on what we're already doing. When we conducted the medical record audit at the end of the study, we had similar patients. Patients were similar between groups assigned to the multifaceted intervention to the education-only intervention. When we looked at whether rehab assessments changed over time, we looked at, did they get an assessment by anyone? Did they have an assessment by someone providing care in the acute hospital? Did someone with rehabilitation, this was someone who would be representing a rehab service, the rehab specialist, so it could either be a rehab physician or a staff member from the rehab service. And then did they access rehab? And so what we saw, there was a significant change in the proportion of patients who were assessed by the hospital clinicians. And this was our target group that we were asking to change practice. But we saw a non-significant decrease in the number of people who were assessed by rehab specialists, and access to rehab didn't change. So we did nothing to change the availability of rehab services, but nothing changed in terms of real patient outcomes.
Excuse me, Liz, we've just got a question that you might want to pause to answer from Alice Cairns, who's asked, were patients who would be returning to remote or rural communities more or less likely to be referred for rehab? Did that come up in your data at all?
I didn't collect data on that. If it was in part of the medical record, if they were transferred before decisions had been made, so they'd come in for thrombolysis and then discharged straight away before planning. If it was just a 24-hour stint in the hospital and then back to the regional centre, they weren't included. But if they were kind of stayed in Sydney before then going back to wherever it was to get their rehab, they would be included. But I didn't actually collect that information, so I can't say.
Right, thanks.
And we found that there was no significant difference in the effectiveness of the interventions. So the hospitals that just received a one-off education session improved just as much as the hospitals that had a lot more time investment. So when we looked at the group as a whole, in terms of what was happening at the end of the study period, in terms of rehab assessment and access, we saw that 71% of patients had a rehab assessment in their treating team. So the rehab assessment was, would this person benefit from rehab, yes or no? That would be judged as an assessment. Most of the people that had an assessment were recommended for rehab, and 91% of people who were recommended for rehab went on to access some form of rehab. So 38% of people were assessed by someone from a rehab service, 81% of people who had rehab needs identified by someone from a rehab service, and every person who had rehab needs identified by someone from a rehab service was able to access rehab. Interestingly, 82 people weren't assessed by anyone, 7 of whom accessed rehab. So they had no documented rehab needs, but accessed rehab. So if you're looking at these figures, 7 people had no rehab needs, access rehab, everyone who had rehab needs identified by a rehab service provider access rehab. So the way that the assessments were being conducted, even at the end of this period, looks like we don't have a rehab service shortfall, because everybody, apart from the people in the acute hospital, everybody who was recommended for rehab was able to receive rehab. So we're looking at these people who didn't get into rehab. So the people who were recommended for rehab but did not access it. So there were 16 patients, 10 of whom rehab wasn't recommended at the time of discharge, 6 because the patient refused and 1 because they'd fully recovered. And so that's perfectly legitimate. Whereas 3 weren't recommended for rehab by rehab specialists. 6 people with stroke symptoms who had rehab needs identified weren't referred to rehab. 2 were discharged to nursing home, 3 were discharged home. And so these are people who had rehab needs and didn't get any sort of rehab, which is, you know, a problem. 1 was an overseas resident who was advised to seek rehab in his country when he returned. Looking at what was determining whether or not you were recommended for rehab or not. So the reasons rehab wasn't recommended. Looking at the criteria recommended nationally in the assessment for rehab tool, so 27 assessments were either because the patient had fully recovered or the patient and family had refused input. Whereas there were 31 assessments, sorry, for other reasons. Most often because for residential care placement and followed by poor motivation or participation. And so looking at information we got from focus groups and audits, it was very clear that anticipated discharge destination, if you were anticipated to eventually live in a nursing home, you weren't recommended for rehab. If you were unwell or medically unstable, you weren't recommended for rehab. And if you were deemed by staff to have poor participation or motivation. So there is quite reasonable evidence that people with severe stroke can make significant gains in quality of life and reduce care burden with rehab. So it might not mean that they can eventually live, it might not mean that they can live at home independently in the community, but it does mean that, for instance, they might be able to regain the ability to swallow food. It might mean that they can transfer with 1 person rather than 3 people in a hoist. So which would then mean that you could go out with your family, you could do car transfers, things like this that make significant gains to quality of life. And these sorts of rehab gains are different from what we normally cater to in our services, but we didn't seem to be able to shift that perception of what people could benefit from rehab. So the rehab needs of people with severe stroke who may eventually require residential care nonetheless are not being identified by acute hospital staff. We know from stroke survivors will tell us that their motivation and participation after stroke can be influenced by therapist attitudes and their relationship with their therapists. So it's really quite concerning that both medical records and focus groups, the data from these 2 sources are telling us that staff are making a call that this person isn't suitable for rehab because they're not motivated or they're not participating in therapy, knowing that these decisions are being made within a week of stroke, when people are highly likely to be having, you know, reactive mood interruptions, you know. And it's a bit like saying, I'm not getting along with this patient, so they don't need rehab. So I think as health professionals working with people with stroke, we do need to perceive motivation and participation. That doesn't really cut it, I don't think, in terms of rehab needs, particularly very, very early after stroke. We need to work with stroke survivors to see what we can do to help them with their participation. If the people are refusing therapy, that's different to low motivation. So I think that's something that we can all keep working on. And medical instability shouldn't rule a patient out of rehab. These people should be stabilised and then looked at once they're suitably stable. So we could see that both interventions improved the numbers of patients assessed for rehab, but still more than a quarter of people weren't being assessed for ongoing rehab needs. So we were able to find that the multifaceted wasn't more effective than education, and the education only is likely much cheaper, certainly much easier. So that's something that we could take away from this. The first port of call should just be education about the tool and education about why it's important to use, and that's as effective as doing a much more hands-on sort of intervention. So the disappointing side of things was that rehab referral practices did not change. So people didn't change the way they referred. And they appeared to be driven by rehab service availability, did not identify any unmet rehab needs for people with stroke, which is very different to what we as clinicians understand. We would always say there's not enough rehab services, but the way rehab needs have been conducted, even after these staff knew that we were trying to identify unmet rehab needs, we were able to, maybe there aren't any unmet needs, maybe that's just something we imagine, or maybe it's just that people aren't assessing according to rehab needs. And provided no data to support anecdotal reports of limited rehab service availability. So no data to be able to advocate for more rehab services. So that was the end of my PhD, and I've been working on that since. So that finished in 2015. So we knew that a change in assessment practices was required to provide accurate data about rehab needs after stroke. So I was fortunate to be able to liaise with the Stroke Foundation. So I was liaising with them quite a lot through the project. So that was it was a real opportunity for me as a PhD student to be able to kind of link in with the Stroke Foundation and liaise with the Stroke Foundation on wording of a new data point about assessment for rehab. So it was an assessment. So for people that aren't aware, this is about the stroke audit. This is conducted every 2 years, and this was added into the audit in 2015. So was an assessment for rehab performed? Did it use the assessment for rehab tool? Did it identify need for ongoing rehab? And also, were they accepted for rehab? And the next question under that is, if not, was it because the service is full, the service can't meet their needs, the patient refused? So it's really trying to map out really clearly, are there people with rehab needs that we're not catering to yet? And then we're also involved in the update of the clinical guidelines for stroke, which now explicitly recommends that everyone should have their rehab needs assessed within 48 hours of admission by members of the interdisciplinary team expressly using the assessment for a rehab tool. And that any person with rehab needs should be referred to a rehab service. So it's not saying they should access a rehab service, because we may well not have the services to provide that, but they should be referred to a rehab service. So we shouldn't be hiding people away from the rehab services. The rehab services need to know who's out there, because they may well be able to take them on, or maybe they're not, but we need to, dot the I's and cross the T's to make sure that there aren't services available for people. So in terms of impact, we're seeing more people being assessed for rehab, and that's steadily improving. So these are numbers from the Stroke Foundation audit. Still 4 in 10 aren't being assessed though. The use of the assessment for rehab tool still needs work. So in 2015, only 11% of people were using it. I don't think the assessment tool has been very widely promoted. But this was something I was interviewed on Radio National last week, and this was something that the interviewer was really quite up in arms about, that this assessment tool isn't being used, simply because particularly people with mild stroke, so people with things like continence and mood and memory problems, these sorts of things, these rehab needs tend not to be picked up unless you're looking for them. And so using the tool means you will look for these things and identify them if they're there, rather than these people going home and having disastrous time at home because they're not back to normal and they're not hooked in with a rehab system. So I think this is ongoing work required to ease into use of the assessment for rehab tool. And the impact of the new stroke guidelines has yet to be evaluated, only having just been released in the end of 2017. And so lessons for others about doing these sorts of projects. Big problem that I had was that I didn't involve the people that I should have used. So we very strongly focused on acute stroke unit staff or the acute teams, and we absolutely should have had better involvement from the rehab teams. So make sure that you are involving key stakeholder groups. If I'd done something different, that would be the big different thing I'd have done. One of the strengths was that through my supervisors, we're able to partner with key stakeholder groups. So with the Stroke Foundation, we had people from the South Australian Stroke Clinical Network and people from the New South Wales Stroke Clinical Network who were able to come out with me when I was doing some education sessions, and that was of real benefit, particularly in New South Wales where I didn't know anybody. Having the New South Wales Stroke Clinical Network leader there did lend a lot of validity to the project. And being able to then feedback, certainly in South Australia we did a lot of feedback to the clinical network here. I think it's really useful to present at lots of different types of forums, so clinical network meetings, academic meetings with looking at different sorts of attendees, so medical and research meetings, allied health meetings, nursing meetings. And it was interesting, I get really different sorts of feedback and questions from different groups. And similarly, presenting in different sorts of journals. So I've presented this sort of stuff in rehab journals, in kind of the implementation science sort of journals, and in medical journals. And it was the interview that I was invited to do just the other day was in the Medical Journal of Australia, simply because they said that they were doing a piece on stroke because there was this big paper out and they wanted someone local, and they just happened to see my journal article, which was lucky for me. So yeah, so that was, I just got lucky, really, right place, right time to be invited to discuss on mainstream media. And it's really interesting with that. So I hadn't listened to Radio National before. The number of people have contacted me since that interview. You know, I've had a couple of stroke survivors, a couple of different researchers have contacted me since that interview, which is, it was a really exciting, nerve-wracking thing to do. So I'd like to acknowledge all the patients and clinicians who participated in the study. It was the study, we received support from the Stroke Foundation and from the Agency for Clinical Innovation in New South Wales to do it.
All right, great, thank you, Liz. There's an opportunity now for people to ask questions, so spot that little Q&A button at the bottom of your screen or the chat button there, and please go ahead and type in any questions you may have. Just got a comment here, first of all, from Marie Braithwaite. Marie says that in acute stroke units where Allied Health is staffed to benchmarks, all stroke patients are assessed by physio, speech and OT, as well as dietetics or social work or clinical psychology if required. And it's usual practice to consider rehab pathways for all patients in those settings, I presume she means. And in this situation, I consider the ART tool clarifies our reasoning and thinking, but does rarely change the pathway already decided by the multidisciplinary team. So as such, it has become a paperwork tool only for rehab. I'm not sure of its use in this type of well-staffed setting. She's just making clear that's just a comment, but is that something you'd like to respond to, Liz?
Yeah, I think there's truth in that. I don't necessarily think it would change the pathway. I think sometimes it does identify rehab needs that would otherwise not be seen. So I think certainly things like continence and mood and memory, I think are very, very commonly not seen. And I think with some teams, the severe strokes, their rehab needs aren't identified. So that's very team dependent and culture of the stroke unit. And if you have a stroke unit that says, oh, this person's got very high rehab needs because they've had a very severe stroke, then whereas other teams might say this person has no rehab needs because their needs will be best met in a nursing home, you know, and you can have, depending on the culture of your team. So I think the philosophy of the assessment for rehab tool might be a change for some teams, but I agree that it wouldn't normally change the pathway, but it might sometimes just highlight an issue that might not be otherwise identified.
Great. And Sandra Lever has sent in another question or comment. Another study would be to compare the outcomes of using the pathway versus usual practice, given the belief that it would not change things.
Because using the pathway, the pathway is only as good as getting into rehab, really. I think using this assessment tool is very much about getting rehab needs documented, and same with Marie's comment. Sometimes it's just about documenting what we're thinking, and because there's this whole rehab pathway transition can be so shady and non-transparent. So getting back to Sandra's question, I'm just reading it here. I think, and it is so dependent too on the relationship between the acute staff and the rehab staff. I think people, because certainly we had some sites that chose not to use the tool at all, and they improved the numbers of people being assessed for rehab too. Yeah, no, I guess it depends on what sort of outcomes we're looking at. So I think patient outcomes aren't going to change unless we're changing access to rehab, which we weren't able to shift. And still with the audit, I don't know that we're changing the numbers of people getting into rehab either. So until we can shift that, then we might not see any change in patient outcomes. So that's kind of the next step is identifying unmet rehab needs. Then once we can identify unmet rehab needs, have some really clear discussions about which cohort deserves or is prioritised to have their rehab needs met, or do we get more services for these people with unmet needs, and then that's when we'll change patient outcomes. But I don't know, that probably actually doesn't even answer Sandra's question. I'm still trying to work that out.
We have another question there from an anonymous attendee. He's asked, were the rehab services specifically represented at the team meetings where patients were discussed?
Not always. So at some they were, at one site, 2 sites. So if I'm talking about the sites where I did the observations, one site they always were, the other site they sometimes were. Yeah. But certainly when I did the education sessions, we had rehab people at a number of the sites, but not all the sites.
We have another comment here that from Katie Moyes, that the stroke units, we're asking about whether the stroke units in this study have an inpatient rehab ward attached to the hospital. She points out a setting where these 2 services available within the same hospital, or in the rehab ward are in the same ward, while sorry, hang on, let me go back. In the regional hospital in Queensland I work in, the acute stroke unit and rehab ward are in the same ward, and while the patients are waiting for a rehab bed, the acute stroke allied health team will continue to provide rehab to the patients. And that sounds like a really great setup, but I imagine it's not available in a lot of hospitals.
Yeah, so there was one site that did have that, and the 2 regional sites had this. It was more like a stroke in-reach team. So they had a rehab team that did community rehab, and they would in-reach and see that anybody that was admitted with stroke really quickly. But so they were the regional sites, and they had it was like a really comprehensive, seamless service, although their acute stroke management medically may not have been as strong as what was happening in the acute stroke units. In the places that had acute stroke units, there was one site, I think there was only one, that did have a rehab ward that was like next door. So it was in the same building, but it was a separate ward. But interestingly, their practices were not smoother, their transitions were not smoother than the other places where they had to get in an ambulance and go to the rehab centre. So that was interesting, and I wondered too how much of their communication happened offline. But certainly what was documented wasn't more seamless than other sites, and access to rehab for their patients wasn't better than other sites either. So, it's hard to know.
Rebecca Pye asks, hi Liz, I work in a regional rural setting and we're trying to adopt your tool here. Our problem's not in the assessment so much, but in the lack of rehab facilities available to us. How do you think we should go about presenting this lack of service using the tool?
Yeah, that's a really good question. That's something that we're all struggling with, and it's really nice to see that people are trying to use it despite the barriers, and that is a massive barrier. Like, kind of, what's the point of using this tool if it's not going to change what I can do with my patients? One thing that I think is important to do is provide this information to the stroke survivor, because then they can at least know that I can get better. I'm not sure where I can go to get this service. It might be that they buy in private, which is expensive and inequitable. But it is also that you can, if you know that you're not as good as you're going to be, if you know that you can potentially improve, I think withholding that information from patients is unethical. I think telling people, I think you would improve with services, I can't find that service, is a tough message to give somebody. But I think it is, if it was me, it's the message I would want to know. I think if it's a real problem, you could get noisy and let your member of parliament know. I'm not sure that that's probably the politic answer I should be saying in a public forum, but
I suppose, Lizzie, what you're saying is if you haven't got the information, you can't do anything to address it. So, if this tool can be used to highlight a gap and allow people to clearly document where there's a gap, you're in a much better position to make a case for change.
Absolutely, and I think as a person who's had a stroke, they need that information too, because it's not helping them to not give it to them, but you are kind of stuck between a rock and a hard place if you're identifying rehab needs but you just can't get people into a service. That does suck. But I was going to say, if you're not in Queensland, because Queensland have got such awesome tele-rehab stuff, but
yeah, and I know that you commented earlier, there's about that your project didn't necessarily highlight a gap in rehab services. The argument being that people who were being accepted for rehab, or that they're identified, their needs was agreed by a number of people that they needed rehab, they were getting a spot. But no, I do wonder whether the gaps are highlighted in other kind of places in the continuum. They're highlighted by people being reluctant to refer in the first place. The ones who are even reluctant to use the tool because they don't want to ask a question that they don't want to know the answer to. And they're the percentage of people who are then assessed by the rehab facilities and they say they don't need rehab. So, is it those people further up the stream where those gaps are actually being identified, rather than people who are being accepted all the way along and then not getting a bed? You only kind of get to that last point in the chain if there's actually a bed ready for you.
Yeah, and a lot of work that a group in Melbourne are doing, looking like with the stroke registry and looking at unmet needs. There's huge unmet needs of people who are living in the community after their stroke. So, and some of whom got rehab, but they would like it ongoing and it stops after 4 weeks or whatever, and some of whom never got it. So this is just a snapshot of what's happening to this particular cohort, like you said, because there's all these other people around them who are not necessarily getting captured as well.
Yeah. All right. Well, we better wind it up there, given that it's almost 12 o'clock. I'll just point out that we've had a couple of other comments coming through with people also emphasising that need to highlight service gaps and needing evidence to demonstrate that rather than hiding them. So thank you to everybody for your contributions. We've had quite a lively discussion and lots of questions coming through. So thanks very much for that level of participation, and thanks very much to Liz for presenting today. I think it's been a really great session. And as Sarah said, this will be has been recorded and it will be available for people to look back on probably sometime tomorrow. And the link will be sent to people who registered, but actually anybody can go into the Health Services Research Association website and find that link. I believe that's correct. Is that right, Sarah?
That's right. Yeah. Okay. Thanks, everybody. Thanks, Liz.